All right, let's jump right in and tackle one of the most important topics you'll face in your nursing studies, fluids and electrolytes. We're going to break down these critical concepts so you can master them for your exams and, more importantly, for your patients.
Okay, so here's our game plan for this session. We'll kick things off with the absolute fundamentals. Then, we'll dive into fluid volume imbalances. After that, we're zoning in on potassium. We'll talk about why we call it the cardiac king. Then we'll cover sodium and calcium, decode some key ECG changes, and finally, wrap it all up with your top nursing priorities. Let's get started.
All right, section 1. Before we can even talk about what goes wrong, we have to get a handle on what right looks like. So we're going to look at the blueprint of our body's balance, where the fluid is and how it's supposed to move around.
So where is all this fluid in our bodies anyway? You might guess it's mostly in our blood vessels, but check this out. That's not even close. A whopping 70% of all the water in your body is actually inside your cells. That's the intracellular fluid, or ICF. The other 30%? That's the extracellular fluid, or ECF, which is the stuff in your bloodstream and between the cells.
Okay, so how does the body move all this stuff around? It comes down to these 4 key mechanisms. You've got diffusion, where solutes just spread out from a crowded area to a less crowded one. Then there's osmosis. Think of water being drawn to where the party's at, moving toward a higher concentration of solutes. Filtration is when pressure pushes fluid and solutes through a membrane. And finally, active transport. This one is the real workhorse, using energy to move things against the current.
Now, this idea of tonicity, it is absolutely vital for you to understand, especially when it comes to IV fluids. A hypotonic solution is kind of watered down compared to our cells, so water rushes into the cells and makes them swell up like a balloon. On the flip side, a hypertonic solution is super concentrated, so it literally sucks the water out of the cells, causing them to shrink.
All right, quick quiz time. Let's put that to the test. If you give a patient a hypertonic IV solution, what's going to happen to their red blood cells? Just take a second to think about it. Okay, you got it? The cells are going to shrink, right? Because that hypertonic solution is more concentrated, it pulls water out of the cells and into the bloodstream.
Okay, moving on. We've talked about how fluid moves around. So what happens when the total amount of fluid in the body is just off? Let's dive into fluid volume imbalances, what it looks like when you have too little or way too much.
This table here is gold. For fluid volume deficit, I want you to picture an empty gas tank. Everything's low and weak. A thready, rapid pulse, decreased blood pressure, flat neck veins. Now for fluid volume excess, think of an overflowing bathtub. Everything's full and powerful, a bounding pulse, elevated blood pressure, and those classic distended neck veins.
Okay, let's try a scenario. Your patient has heart failure. You listen to their lungs and hear crackles. You feel a bounding pulse, and you see distended neck veins. What's your first thought? Yeah, this is a textbook case of fluid volume excess. The crackles mean fluid is backing up into the lungs, and that bounding pulse and distended veins scream fluid overload.
All right, next up is potassium, and we're giving it its own section for a very, very good reason. We call it the cardiac king because it is that important. Seriously, even tiny little changes in potassium levels can cause deadly heart problems. This is one electrolyte you do not want to mess with.
And here it is, the magic number, 3.5 to 5.0. I'm not kidding, you need to burn this range into your memory. It's one of the most critical lab values you will ever learn. If you see a potassium level outside of this range, your alarm bells should be going off, loudly.
So what happens when potassium is too low or too high? Well, the signs are basically mirror images of each other. With hypokalemia, that's low potassium. Think low and slow. You get muscle weakness and a flat T wave on the ECG. But with hyperkalemia, high potassium, everything gets super intense. You see those classic tall, peaked T waves, and in severe cases, it can even cause paralysis.
Okay, everyone, listen up, because this is probably one of the biggest safety rules in all of nursing, and there are no exceptions. You never, ever give potassium by IV push. Pushing potassium straight into a vein is like a death sentence. It can literally stop the heart. It always, always has to be diluted in an IV bag and infused slowly over time. No shortcuts.
All right, we've covered the cardiac king, potassium. Now let's shift gears and talk about 2 other major players, sodium and calcium. If potassium rules the heart, then sodium rules the brain, and calcium is all about the nerves and muscles.
So here's the deal with sodium. If you see a sodium problem, you need to think neuro. The brain is so sensitive to sodium changes. And what's really interesting is that whether it's too low, hyponatremia, or too high, hypernatremia, the number one thing you're going to see is an altered mental status. And here's a huge tip. Hypernatremia can cause lithium toxicity. Remember that one.
Now for calcium. When calcium levels drop, think of the nerves and muscles getting really twitchy and irritable. And there are two classic signs you have to know. First is Trousseau's sign. You pump up a blood pressure cuff and the patient's hand curls up into a spasm. The second is Chavostek's sign. You tap on the facial nerve and their face twitches. You see either of those, you should be thinking hypocalcemia.
Let's put that into practice. Imagine you're caring for a patient who had thyroid surgery 2 days ago. You gently tap the side of their face and you see their lip twitch. What's going on? That's a positive Chavostek sign, which points directly to B, hypocalcemia. This makes perfect sense because the tiny parathyroid glands that control calcium live right behind the thyroid and can easily get bruised during that kind of surgery.
Okay, this is where it all comes together. We're going to see how these invisible chemical imbalances actually show up as clear, readable patterns on an ECG. Being able to decode these signals is a massive part of being a great nurse.
This chart is your best friend for connecting the dots. For hyperkalemia, you're looking for those big, tall, peaked T waves. They look like little tents. For hypokalemia, the key is the U wave. Just think, you need more K. Now for calcium, it's all about time. Hypocalcemia makes things take longer, so you get a prolonged QT interval. Hypercalcemia speeds things up, so you get a shortened ST segment.
All right, another quick check. You're looking at your patient's ECG, and you notice this weird little bump after the T wave. It's a prominent U wave. What electrolyte problem are you suspecting? If you see a U wave, your brain should immediately scream hypokalemia. It's the classic sign of low potassium. Okay, let's bring it all home. We've gone through the science, so now let's talk about what you actually do. This is about turning all that knowledge into action at the bedside to keep your patients safe. These are your key nursing priorities.
These are your non-negotiables. With calcium imbalances, be on the lookout for fractures. With severe low sodium or calcium, get seizure precautions in place. Don't forget, when calcium goes up, phosphorus goes down. You have to know that calcium gluconate is the antidote for magnesium toxicity, and always connect low sodium with a risk for high lithium levels. These are lifesavers.
Okay, last scenario, and it's a big one. You have a patient getting IV magnesium sulfate. You go to check their deep tendon reflexes, and there's nothing. They're absent. What do you do right now? This is an emergency. Absent reflexes are a sign of magnesium toxicity. Your first immediate action is to stop the infusion. Then you prepare to administer the antidote, IV calcium gluconate.
So I'll leave you with this final thought. A patient suddenly develops a brand new cardiac arrhythmia on the monitor. What's the very first electrolyte you're going to check? It's got to be potassium. Always. Because of its massive impact on the heart, you always think potassium first. Mastering these concepts is key to keeping your patient safe. Don't forget to like and share the video.